Hi, you're watching India Post Live. I'm Shivraj, and today we're discussing how the internet is making you, or at least making you think you're ill, the phenomenon of cyberchondria. You can join in on the conversation by logging onto our website, indiapostlive.com. You can also tweet with us using the hashtag IndiaPostLive. So, if you've got eyes that go red, you perspire, you sneeze, you think you're ill, what could it be? No, you don't need to go to a physician. Instead, a lot of people are now going to Google. There are health apps, there are treatment apps, there are smartphones, helping you along the way. But if these are all the symptoms, then let us diagnose you as a hypochondriac.
The Oxford Dictionary describes hypochondria as abnormal chronic anxiety about one's health. Hypochondria, all right, but self-diagnosis using information found on the internet, are we making it worse? There is even a term for that, cyberchondriacs, a person who compulsively searches the internet for information about particular real or imagined symptoms of illness. Doctors are often faced with people coming to them for treatment after self-diagnosis. It is never about what could be wrong with me or these are the symptoms. In fact, it goes somewhat like this. I have been diagnosed with lung cancer. Please treat me, and oftentimes even the course of treatment is decided by the patient. So what happens to the old-fashioned doctor-patient relationship?
With a wealth of information out there in the cyberspace, what happens to the relationship between doctor and patient? Well, joining us in studio is Dr. Bobby, who is a senior physician and also now working in the area of public health policy. Dr. Bobby, is it a good thing or a bad thing? Because then, the relationship between patient and doctor goes out of the window and there's all this self-diagnosis happening.
Information in the hands of people, particularly relating to their own bodies, is not a bad thing.
Okay.
There can never be too much of knowing your own body. What then comes up is the question of where does this knowledge transgress into the areas of a physician's domain knowledge. Physicians traditionally have been people who knew everything about your body, your symptoms, your illnesses, and essentially wrote a chit of paper which you went to a pharmacy and got your prescription filled without much of a conversation as to what was wrong with you or what would be the potential downsides to the medications that you're going to take. Essentially what has happened today is, thanks to the internet and thanks to Google, people are able to look up what's wrong with them and have a better understanding of what they're going through. They are able to get technical information. They are also able to draw on the experiences of other people who have gone through similar symptoms and potentially have an idea as to what might be the course of their treatment. The problem is a resetting of the relationship between the doctor and the patient. The doctor who seemed to know it all today finds themselves
not demigods anymore.
Not demigods. So there's that pushback that's coming in. I fall on the side of there can never be too much of information in the hands of the patients because after all it's their body, it's their right. What then is required is the other understanding that knowledge or information is one thing. Application of it requires specialist insight, and that has to be in the hands of the doctor. It's a relationship between the patient and the doctor that
and the expert
that kind of gets you your treatment outcome. One-sided knowledge or one-sided application of it doesn't really help either or both.
But it doesn't help if patients feel that they're getting tired at a regular instance and then they go online and they read these reams of graphic details about brain tumors, and so they get a little hyper about it. That is dangerous though, because in the hands of laypersons, sometimes information can be misconstrued as well.
And that's where the responsible consumption of information also needs to be played up. It's one thing to be an indiscriminate consumer of information and then try and find yourself being the patient in every one of those settings. It's the domain expertise of a physician on the other side to sift out what's relevant, what's irrelevant, and to contextualize your symptoms and say, this is where your treatment is, this is what's wrong with you, and then to hold faith in the hands of a competent doctor with the line of management that's been prescribed. Oftentimes we try and second guess our physicians. That's not a good thing, because it does not help the relationship of trust, and second, it does not build towards a partnership of achieving a cure, which is what both sides want. The patient wants a cure, the physician wants a cure. Second guessing or bombarding people with information that may be extraneous or non-contextual doesn't really help.
And apart from that, I mean, of course, accessing the information, having that dialogue with your doctor, putting them on the spot, because you map then what it means to what prescription he's given. But there's the flip side as well, where people are now jumping onto self-medicating themselves. So what they do is they go online, they find out what they think are their symptoms, and then they draw up a list of things they should be consuming and go to the chemist shop and pick them up. So unlike in the West, they're not regulated here, right? No one asks for a prescription.
So this is the example of do-it-yourself, DIY kind of medicine.
Yeah.
Most of us, when we aspire to build a house, we want to kind of look at our drawings, we kind of do the 3D sketches online, but none of us really go about building our own houses because we know the limitations of our competence, right? In the same way, we need to recognize that there are limits to our competence, however much we are informed. We cannot go about picking up, based on strands of information, however compelling they might look, the tools and techniques that a specialist needs to apply into our own context. You cannot, for example, assume that a cough of a certain duration, which is associated with some kind of fever, is automatically tuberculosis. I mean, tuberculosis drugs are available over the counter. That's a travesty. We need better regulation around it. But just because you think you have it and you go ahead and medicate yourself puts both yourself at danger and runs the larger risk of creating drug resistance out in the community. And so it doesn't serve your physician, because you coming there after 3-4 days of having medicated yourself, you probably don't disclose
and
what you've already done.
tuberculosis is a very sensitive thing, because if you do not, I mean, if you medicate yourself and if you do a whole lot of things, the drug resistant variation is a big threat.
It's 200 times more expensive to treat, if at all it can be treated. And that's the kind of mess that we find ourselves in when people begin to take specialist knowledge. Democracy is all good, democratization of knowledge is all good. They take that specialist knowledge and then they apply it to themselves, and we have a willing partner in a pharmacy sector that's fairly ill-regulated. Drugs that should not be prescribed by non-qualified physicians or be dispensed in the absence of those prescriptions, that's not done. Patients who indulge in that kind of behavior are essentially doing this equivalent of building their own houses on very faulty engineering principles. The outcome will be a catastrophe, and that's what we see in individual cases where people do their own medications and force their physicians, sometimes who are less confident of their own knowledge base, to follow certain lines of treatment based on what they've read up on the internet.
And how do people make decisions when they go online to what is legitimate and what isn't legitimate advice? Because again, a lot of the information out there in the cyberspace is a lot about people who are now getting into this and starting to also scaremonger among a lot of people.
That is why physicians are trained for long periods of time. Right from day one, they are taught to sift between what is presented as a symptom and what is elicited as a sign to arrive at a diagnosis. Most of what lay people describe for themselves are correctly classified as symptoms. Symptoms are not necessarily the disease. The discrimination between symptoms, signs, and disease and the line of management is domain expertise. So it's good. It's good to have a line of sight. It's just like it's good to know how your car is built. You're not going to necessarily build your car, right? Same way, it's good to know what your body is going through. It's good to know the details of what a treatment might look like or how it kind of has an impact on your body. But it isn't wise to actually take the decision into your own hands, because you don't have contextual information. You don't have the ability to discriminate between what's a symptom and what's a disease.
What about the charge that a lot of people on the internet, semi-professional, want to make you think you're ill so that you really do get into this whole vicious cycle of being drawn in and maybe saying that's more authoritative than actually going to a physical physician?
Well, that's completely illegitimate. You cannot, and I as a physician or I as a public health professional would always come down on the side of a direct face-to-face conversation between a patient and their care provider. Nothing can substitute that. We do have the era of telemedicine. That's a very specialist way of doing some stuff.
In fact, that was my flip side question, was that technology also can be an enabler, because telemedicine has become the new thing to get to remote areas.
So telemedicine is not about the patient
Right.
trying to Google out or trying to find information for what they are going through. Telemedicine is an application of extending the hands or the reach of a provider of specialist care from a place where they are at to a place they are remote from. And that's a different way of looking at provisioning of care. It's not about accessing your own care. And anybody who comes up on the internet and says, I've got a better solution or I've got a better diagnosis for you, is essentially misleading people.
And so what happens when someone's done so much damage to themselves? Because it's not just physical, it's also psychological, and they come to a physician and ask for a solution. Are physicians now a little more privy to what's been out there in the cyberspace as well?
Well, physicians, I hope, are as net savvy as their patients that they're treating. That's one part of it. Second, disclosure. Does a patient come along and tell in confidence that they have been able to access information and this is what they've done? More often than not, patients do not disclose the full extent of their activities. We just have to even just ask ourselves. I mean, even when we go into our physicians, how do we kind of communicate with them? We tell them we've got a set of signs and symptoms, and that's about it. We don't tell them what we've done unless really probed, or unless they are able to figure out that something's gone on here that's probably a result of some other stuff having been done or some medicines have been consumed. It's really deduction on the part of the physician to kind of figure out, has there been some amount of self-practice, self-medication before they've come here. Now, it's easier when you're dealing with physical symptoms, when you're dealing with systems other than the mind. It becomes particularly difficult when you're talking about people medicating themselves for perceived psychiatric illnesses.
Absolutely.
Or they think that they have got something going on in their head and they want to treat themselves. That becomes even more difficult.
Dangerous. And then the second question, so while the patient-doctor relationship has seen somewhat of a change with this whole phenomenon, but also going back to what you said in the opening, is that chemist shops, are not questioning, they're not being critical of the kind of demands coming from patients at their counters. Can, from a public health policy perspective, from a regulatory framework, something be done there?
Absolutely. We have a pharmacy council that's supposed to regulate the profession of pharmacists. Pharmacists are supposed to be licensed. They are supposed to go through a whole gamut of regulation and requirements before they're able to set up shop. Every pharmacy is supposed to have a qualified pharmacist behind the counter, not running the business, but in the profession of dispensing out what is a prescription from a qualified practitioner, and the ability to discriminate what's going on and how it needs to be compounded or dispensed, and the instructions that need to go to the patient along with the prescription. That's one part of it. Second, the Drug Controller General of India and the state drug authorities have the ability and the legal bandwidth to be able to say to transgressing pharmacies,
Okay,
look, this is not on.
We've got a few tweets as well. Cyberchondria, well, Nani, Dadi ki Nushke have become health apps now. Crazy people we are. So the whole phenomenon of apps also now suddenly becoming diagnostic tools where you strap them on or you look at them. That's rather also falling into a very dangerous terrain.
Well,
it's not information. It's actually taking on from what you're feeding in and then throwing back
apps are good.
diagnosis.
Apps are good
Okay.
when it is about figuring out what your symptoms are or what's the extent of your symptoms and how you translate those symptoms into signs. For example, you say, dil ghabra raha hai. An app on an iPhone could very well tell you your heart rate is going up. Dil ghabra raha hai, heart rate going up, you've got a measurable thing. What's the symptom
Okay.
has been translated into a sign. Eliciting that, apps have got a great place. Technology has got a great place to do such things. What to do with that increased heart rate?
Should go to a doctor.
Should that be prescribing an antiarrhythmic? Good heavens, no.
No.
It should be an aid to getting better treatment or a better diagnosis. It's an additional stream of information that comes in, but the domain of making decisions is somewhere else. Apps cannot make that decision. However much we want algorithmic practice of medicine, you want evidence-based medicine, you still cannot eliminate the role of a physician who discriminates between what is relevant information and what's the context in which
Interesting
it
you
needs to be
say
applied.
that, because again there's another tweet saying, as a smartphone user, there are a number of healthy apps available and it helps in giving at least the basic tips.
Yeah, so long as you know that your body mass index is out of whack, so long as you know that your heart rate is kind of going a little bit haywire, so long as you know that you're not sleeping well, or the number of steps that you've taken in a day is not too good, or if you've got other invasive monitoring like your blood glucose levels are slightly on the higher side, those are all information that enables us to be able to present that to the person who then mediates a treatment for you. It cannot replace that treatment initiation or a management role.
Okay, we have someone online, Wasim Zaidi, via Skype. Do ask a question of Dr. Bobby. We're discussing the whole phenomenon of people going online and self-diagnosing. Vamik, can you hear us?
My name is Vamik. Yeah.
Yes.
Okay. Yeah. So, can you hear me?
Yes. Go ahead.
Am I clear? Hello?
Yes.
Hello?
Yes.
Hello? Hello?
Yes, Vamik, go ahead. Ask a question of the doctor
I
in
can't hear your
studio.
voice. Can you hear me?
Yes, we can hear you.
Sorry. Yeah, basically there are just a couple of, so there are two sides to it. The first side is that, taking medication, looking for medication is a very simple thing. But if the diseases are so generic, then why do we need to have different medicines for the same problem? I mean, let me talk
Sorry.
about something very simple. Let me talk about a headache, So there is a test, there is a Faradon, there is a Nimusulide for this. For that.
Okay.
So, I mean, if the disease are so big, we can just go to the
Okay,
medical side.
so we seem to be having trouble hearing him, but if I...
Everyone can just take a different.
Okay. Okay, there's this whole debate out there, what's good, what's not good. Nimusulid, he raised a moot point, is there's been so much talk about being bad and good, and then people go on and make their decisions, but they don't look at the kind of contradictions that might happen if they take it, right?
This goes to the heart of continuing medical education, and something that I'm really interested to see more of in this country. At this point in time, once you've graduated from the medical college and you've got your postgrad qualifications, or wherever you stop at and you've got your registration, the necessity for you to keep upgrading your information, your knowledge base, and being tested on it, that's such a weak area in our healthcare training program.
And what about healthcare training at the level of pharmaceutical sellers or chemist shops? Because there's an interesting tweet saying the whole mechanism seems flawed as far as India is concerned, because you can buy any medicine over the counter.
So we are good at one of qualifying exams. We are not good at ongoing assessment of who's being competent. And that's something that we need to set in place if we have to avoid catastrophes like multi-drug resistance in multiple disease areas, or people diagnosing and medicating themselves with medicines that really are inappropriate for their condition. Whether it's physicians, whether it's pharmacists, we need to have an ongoing continuing education program, an assessment program to license them, and that needs to happen periodically. Unless we get there, what we will have are people practicing with outdated information. Let's face it, I mean, people do not have the incentive to keep themselves updated with what's happening, or what's today, what was considered good yesterday, not being considered appropriate
today. But yet
today.
there are also doctors who now, in fact, are leveraging the cyberspace to their advantage and actually being more updated as well.
Which is a good thing.
Which is a good thing.
And this is where, I mean, I really come strongly on the side of more information, both in the hands of patients, because they keep the doctors on their toes, and doctors then, if they are motivated, if they are not kind of intimidated by that, or if they don't feel defensive about it, it actually becomes a tool for them to assimilate this new information and upgrade themselves and be at the cutting edge of what they provide as care for their patients.
So, we're discussing cyberchondria, but from an advocacy point of view, what can be done, say, from the medical fraternity's perspective, to try and educate people better on navigating the online space?
The role of the doctor is as central as it was 100 years ago, though it's not the same way as it was 100 years ago. Information gradients are being leveled by the internet. And so the doctor is no longer the sole fount of wisdom. So long as we understand that, and then we reinforce the position of the physician as the responsible initiator of what is a treatment, we are good. I'm not sure whether we're doing a good job of communicating that. And physicians, by their unwillingness to work with a more literate patient, or being defensive or being outright nasty with them, doesn't help matters at all. In fact, it makes somebody who's an informed patient walk away with a sense of, I need to find better solutions, or I can do this on my own because I'm as informed as a doctor. Communications, and especially the positioning of the physician as still the responsible gateway for good treatments, needs to happen. This other gateway that needs to be shut off is the provisioning of drugs across the counter from mushrooming pharmacies. It's a business.
Right.
The volume of,
and it's all feeding off each other.
It's all feeding off each other. And so therefore, it also sets up very unhealthy dynamics of patients figuring out where their preferred provider of medicines are. So they are able to call up on the phone, describe something, and medicines are delivered at home. That doesn't work. In fact, that's downright dangerous, and that needs to be regulated. There needs to be a way that drugs are tagged, that they are tracked through till from the point of production to the point of consumption, and there are additional pieces of paperwork that legitimizes that transcript.
So who does this? Because say for instance in the United States, you can't buy anything over the counter. There are different gradations for what you can and what it's mandatory to be prescribed as well.
So we have the framework of the Drug Control General in this country.
But why isn't it working on the ground?
So what do we have? We have less than 400 inspectors for the entire
country,
and for the Drug Control General. And I may be slightly off on my numbers at the state levels, but it's not a question of an absent framework. We do have the framework, we do have the statutes on the book, and they're pretty stringent. It's a question of how do we enforce it? Do we have the manpower to enforce it? Unfortunately, this part of the world of health provisioning, all of them are seen as expenditures on the national government or the state government side, and so therefore putting additional manpower into that side is seen as a budget balancing exercise. So if you can't balance your budget, if you need cuts to be made, then it's best to cut on the human resources and the health side. It's best to cut regulators' salaries off, or not have those posts filled in. We have to reprioritize health. We have to reprioritize the provisioning of regulators and their capabilities.
Okay. We do have via Skype Dr. Nisha Khanna, who's joining us as a psychiatrist. Dr. Nisha, we've been discussing the whole phenomenon of hypochondria, and Dr. Bobby in studio was talking right now before we came to you about the whole idea of trying to regulate it from a perspective of what's available in terms of medicine. But from a user perspective, what are the dangers of someone getting into this cyberspace and then start self-diagnosing and sort of getting worried about what's happening? What are the implications on them in terms of psychologically?
The basic thing is, when you are talking about, as in my practice also, a number of patients and coming into the clinic and they are diagnosing, even self-diagnosing about depression or a personality disorder or a psychopath personalities. As these days the awareness is so much, the people are reading the articles or they are reading online on Google about these diseases. And in the end, they are finding they themselves are suffering from these diseases. They are not actually recognizing what basically the factors, how these people are, whether people are actually getting into, because in psychiatry there are lots of disorders. I would say more or less, if a normal person will read disorders, the person will start thinking, I must be having this disorder.
Absolutely. So what does that do to the patient? Because clearly it raises levels of anxiety as well, doesn't it? Makes them a little more paranoid.
Definitely. Even the patient started having self-medications.
Sure.
So that's most of the dangerous part. I would say number of times I'm dealing in counseling also. So the patients are coming to clinic and they are applying all the techniques by their own. Maybe sometimes it depends upon the situation to situation, what particular thing or what particular therapy is applicable to you. So people are generalizing those thoughts, those statements, whatever is provided on online or on the newspapers or through medias, whatever the things they are getting, they are applicating the same information as it is. They are not thinking there is a need to verify the information, because some thinkings or some generalization is not for the whole public. That is for specific or situation related. Like reading about the depression article, number of times people are coming to me and telling me that we are suffering on depression, where there is just a general stress, something is there.
And
So
Dr.
I'm finding.
Nisha, Dr. Nisha, how do you tackle people who come to you after having read all this and sort of throwing up all these possibilities and permutation combinations? How do you counsel them to perhaps take a step back and see it rationally?
One thing is that suppose the person is suffering from any personality disorder, there are lots of psychometric testings. Even for a depression also, there are lots of tests where you can diagnose whether the depression is there with the patient or not. And definitely when you are talking about the symptoms, basically we are always talking about the person is feeling low, so person is suffering from depression. Person is having suicidal tendency, person is suffering from depression. But number of times, even as a doctor also, I am finding it out, the patient are suffering from number of disorders. It may be not a personality disorder, maybe not a paranoid or a split personality, or not only always about a psychopath, which is a very critical or a psychiatric term. It's not an easy for a doctor even to diagnose those diseases. But when people came with these disorders, or already studied about a lot about these things, they're asking a question, a list of questions they already have their mind, because it's a excess of everything is bad. So excess of information about a disease also is a bad thing for them, because they became self-conscious, and sometimes they are skipping the smaller steps where there is a need to be ignorant. Like for the smaller things, there are not no need to take a precautions. For a smaller spec, they became overprotective about the things, because so
Right.
much of information is there, so they gathered so much and they think that they themselves are the doctors. So we people don't know anything, and it's very difficult for them to deal with us as a psychologist or as a counselor, and letting them explain those things, because in a logical manner, when we have the diagnosis test and those tests, they are not coming out as a with disorders, then only they people are satisfied. And more or less this yes, in this situation, the people who are having all these things, they are more or less the highly qualified people, either the CEOs of the companies, or well established business
Okay.
persons, or the professionals.
And Dr.
So
Nisha, are you also on the internet? Are you also surfing? Because when we're having this discussion, there is a sense that the medical fraternity sometimes shies away from the internet. So perhaps being maybe a curve ahead of your patients and saying, yes, I've read that article, but let me tell you that there is a whole back end story. There's a lot more to it.
yeah, I myself is also writing my blogs. There is
Okay,
no doubt that it is the information, whether you have the knowledge of that subject, that particular
the
thing.
domain
So,
expertise.
yeah, that is expertise, because if I will talk about myself, I'm into this profession from last more than 14 years. So it's a huge experience behind that. If you are writing and if you are saying something, it is not that reading something and applicating the same information in your life as it is, which is there is a need to be modification. For example, if in life you say that we should think positive, or in the books it's always speaks truth, but in the practical life it's always with conditions apply, wherever the situation is practical. It's not written in any book, but it is the practicality.
Absolutely.
If that child is studying in the arts or commerce group, the I would say the teachers are teaching that the credit and the debit, but in the practical life, the debit part is it's totally opposite. The credit goes to the debit and debit goes to the credit. So the practical things are totally different than the theory. We are thinking that the theory is as applicable in the practical life, but there is a need to be some manipulation, or sometimes if there is a need of the practicality of the situations. You can't apply the same things to everywhere. Like never give up quote, you can't apply to each and every patient. Sometimes there is a need that patient, there is a need that person is so manic, and person needs to go into the reality and see the pessimistic part of the life.
Okay, so Dr. Nisha, when you're faced with patients who come to you and have sort of tried to self-medicate, self-diagnose, how do you counsel them to see reason? How do you counsel them to sort of take a step back?
The first basic reason is that I told you that to make them realize that they are not the doctors.
Okay.
First thing, it's not an easy to admit them that they are coming to a professional and they are not expertise or qualified in that particular field. And when they have a book of questions or a list of questions, we have to give them the logical answers.
Okay.
In those things, most of the time I'm using with the patient the psychometric test. For
Okay.
example, the person is telling I am a problem of a high BP or a I would say diabetes. So we will recommend the patient to go for the testing. Either you go the sugar test or something, or either a BP test. The same
Okay.
way all the psychometric testings are available in the market. Either a depression, either a bipolar, either a split personality disorder, either a borderline case of personality disorder. So these sort of personality or a psychopath. So that's I'm telling you there are particular traits.
Okay.
Or the psychometric diagnosis test which are validated. So
All right.
then you will tell them these are the validated tests, and especially these tests are not from India. These are from all over the abroad, and they are standardized tests. Then only they are able to admit. And sometimes they are going to different doctors even to recheck whether the doctor is telling the truth or not.
Okay. Dr. Nisha, thank you so much for joining us there via Skype. Dr. Bobby, we're going to let you have the last word to put it all in perspective. I think the one big question Dr. Nisha raised was verifiable information. And the second thing is, how do you tackle patients who have gone that far already? What is the mechanism in terms of counseling, advocacy to do the right thing?
We need to figure out a way, the same way that we have done statutory warnings, is to figure out how to communicate a statutory warning to people who consume health information on their own, that there are limits to this knowledge. Application of this is to your great detriment if you do it under your own guidance or your own free will, without supervision. Figuring that out as a ticker tape running across websites, I'm not sure whether that's the way to do it, but somewhere along the line, the equivalent of it needs to be communicated to people. That while free information is available, application of it is entirely risky behavior. Second is to then reinforce that confidence back into the medical fraternity to be able to be cognizant of what's out there and be able to respond with confidence that they are in the right place to make the decisions.
All right, Dr. Bobby, thank you very much. Dr. Nisha, thank you very much for joining us. You can also join in on the conversation by logging on to our website, indiapostlive.com. You can also continue tweeting us at #IndiaPostLive. Thank you for watching.